All right, the next chapter is going to be chapter 30, chest injuries. National EMS Education Standard Competencies for this chapter. Trauma. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. We will look specifically at chest trauma. So we need to be able to recognize, assess, and manage blunt versus penetrating mechanisms, open chest injuries, impaled objects in the chest. We'll look at the pathophysiology and assessment and management of blunt versus penetrating mechanisms, hemothorax, all of the thorax, pneumothorax, open, simple, and tension. We'll look at the pathophysiology and assessment and management findings for cardiac tamponade, rib fractures, flail chest, and commotio cordis. Commotio cordis. Introduction. Chest trauma causes more than 1.2 million emergency department visits each year. Chest injuries can involve the heart, can involve the lungs, and the great vessels. It may be the result of blunt trauma, penetrating trauma, or it can be a combination of both penetrating and blunt trauma. Immediately treat injuries that interfere with normal breathing function. Very important statement. So if a patient has a chest injury and it is affecting their ability to breathe, you need to fix that issue in the primary assessment. So again, immediately treat injuries that interfere with normal breathing function. Internal bleeding can compress the lungs and heart. Air may collect in the chest, preventing lung expansion. Let's review the anatomy and physiology of ventilation, oxygenation, and respiration. Ventilation, the body's ability to move air in and out of the chest and lung tissue. It has two processes. One is active, one is passive. You have an inhalation phase and an exhalation phase. The active process requires muscle contraction. The passive process requires muscle relaxation. The important muscles of breathing would be the thoracic, the intrathoracic muscles or intercostal muscles, and the diaphragm. Oxygenation is a process of delivering oxygen to blood by diffusion from the alveoli following inhalation into the lungs. Injuries may affect ventilation and or oxygenation. Thoracic skin, muscle, and bones. Similarities to other regions also has unique features to allow for ventilation, such as striated muscles, skeletal muscles. Between the ribs, just below each ribs, there is a neurovascular bundle which contains a nerve, artery, and a vein. So the neurovascular bundle supply the rib cage. with nerve endings and blood flow. The pleura is the membrane that covers the lung tissue, and the pleura has an inner lining and an outer lining. So you have the visceral pleura. The word viscera means organ, so the visceral pleura is attached to the lungs. I have the parietal pleura, which is attached to the outer cavity. Outer lining is the parietal. So that's attached to the outer thoracic cavity. A small amount of pleural fluid is found between the parietal and visceral pleura, and the purpose of this fluid is to prevent friction when the lungs expand. And this is a space that can start to collect air and blood. So if air and blood enters the pleural space, it will expand and cause the lungs to collapse. Vital organs such as the heart are protected by the ribs, which are connected in the back to the vertebrae and connected in the front to the sternum. Not all of the ribs directly attach to the sternum. The mediastinum is the space between the lungs. So that's what is referred to as the mediastinum, and it contains the heart, the great vessels, the esophagus, which is posterior, and the trachea, which is anterior. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. And when we exhale lying down, the diaphragm can come as high as the nipple line. So if you suspect injuries to a patient's abdomen, suspect injuries to their chest. And if you suspect injuries to the chest, suspect injuries to the abdomen. Mechanics of ventilation. Intercostal muscles and the diaphragm contract during inhalation. That's negative pressure. Intercostal muscles and the diaphragm relax during exhalation. That is positive pressure. You need to be very familiar with negative pressure and positive pressure. The body should not have to work to breathe when in a resting state. So, negative pressure is created when the thoracic cavity expands, and that's what inhalation does. It increases the volume of the thoracic cavity. Exhalation decreases the volume, and volume and pressure works inversely. Volume and pressure works inversely. So if volume increase, so if the size of something increases, that's what volume is, then the pressure in that space is going to drop. That's negative pressure. If the size of something decreases, if the size of a space decreases, it will cause the pressure in that space to increase. So volume and pressure works inversely. Make sure you understand the concept of negative pressure and positive pressure. Now, patients with a spinal injury below C5, cervical vertebrae number 5, can still breathe from the diaphragm. So if the injury is below C5, the patient can have paralysis of the 4 extremities, that's quadriplegia. So they can have quadriplegia, hemiplegia, paraplegia. Quadriplegia would be paralysis of all 4 extremities. Hemiplegia would be paralysis of half of the body. Half of the body is paralyzed. And paraplegia is paralysis from the waist down. So what this slide is saying is that if the injury is below C5, they can still breathe. The diaphragm can still work. But if the patient's spinal injury is above C3, they may lose their ability to breathe. Because for most persons, the phrenic nerve that controls the diaphragm originates from C3 to C5. And there's a saying in EMS, C3 to C5 keeps the diaphragm alive. C3 to C5 keeps the diaphragm alive. So if they get an injury close to C3 or above, they can stop breathing. You have a patient in serious trouble at that point. Tidal volume is the amount of air moved into or out of the lungs in a single breath. Minute ventilation is calculated by multiplying the tidal volume by the number of breaths per minute. Changing either number affects the amount of air moving through the system. So what this slide is saying is, if the patient ventilation is decreased, that can affect their tidal volume. And it's also saying if the patient breathing rate changes, that can also affect the patient's tidal volume. So chest rise and breathing rate per minute can affect tidal volume. So these are things you have to look at when assessing the patient's breathing. So that is a review of the anatomy and physiology. Let's look at the injuries. So there are two types of chest injuries. Can be a closed injury, can be an open injury. In a closed chest injury, the skin is not broken and it is generally caused by blunt force trauma or blunt trauma. Closed chest injuries usually result from blunt trauma, such as when a patient strikes the steering wheel or an airbag in a motor vehicle crash or is struck by a falling object. A closed chest injury can occur when a seat belt is worn. And this is where you think about your pre-collisions. And it's not just knowing, swatting what it is, it's understanding what you need to look for. So the first collision is when the car hit an object at a particular speed. So the car hits a wall at 120 kilometers per hour. That's the first collision. The second collision is when the body hit the interior of the car at 120 kilometers per hour. And the third is when the structures inside of the body hit the interior of the body at the same speed. Do not swat that. Understand what it means. So when I think about the first collision, I am thinking about access to the patient. The first collision is when the car hits an object, right? So when you process the information regarding the first collision, you're thinking about access. Do I have access to this patient? Do I need to create access to this patient? That's the first collision. The second collision is when you examine the interior of the vehicle. So you're looking for deformity at the dashboard, up and lower. You're looking for deformity at the steering. You're looking for spider webs in the windshield. And persons who are tall go over the dashboard or over the steering. Persons who are short will go under the dashboard or steering. So when I think about the second collision, I am thinking about physical injuries to the patient. Which part of the patient deformed that part of the vehicle? That's what I'm thinking. That's my understanding. When I think about the third collision, I am looking at the patient. So this is when you're looking at the patient for impact points. I'm looking at the patient for impact points. And anywhere I see an impact point on the patient, I'm thinking about which structures are underneath and what is the function of those structures. So when I think about the third collision, I am thinking about internal injuries. You must have understanding behind your reading, and that is lacking. Read to understand. Very important. Now, closed chest injuries can cause significant cardiac and pulmonary contusion, and a contusion is a bruise. If the heart is damaged, it may not be able to refill with blood, or blood may not be pumped with enough force out of the heart. And if the heart is not able to pump blood out adequately, then the cardiac output will decrease. You have a patient in shock. Lung tissue bruising can result in exponential loss of surface area. If surface area is lost, this will affect respiration. Rib fractures may cause further damage. An unstable rib can puncture a lung. In an open chest wound, in an open chest injury, an object penetrates the chest wall itself. It can be a knife, bullet, piece of metal, or a broken end of a fractured rib. Do not attempt to move or remove the object. Blunt trauma to the chest may cause rib, sternum, and chest wall fractures. Bruising of the lungs and the heart, damage to the aorta, vital organs to be torn from their attachment in the chest cavity. Signs and symptoms. Pain at the site of injury, localized pain aggravated or increased with breathing. So they're gonna have pain localized and it's going to be aggravated by breathing. So most of these patients will tend to breathe shallow if they are conscious. Bruising to the chest wall, crepitus. And crepitation or crepitus is when bone ends rub together under the skin. Broken bone ends are rubbing under the skin. They can also have emphysema, which is air being trapped under the skin, subcutaneous emphysema. They can have dyspnea, which is difficulty breathing. They can have hemoptysis, which is coughing up blood. And if they are coughing up blood, it's coming from the lungs. If they are vomiting up blood, it's coming from the intestines. Failure of one or both sides of the chest to expand normally with inspiration. So they can have what is called paradoxical motion, right? Paradoxical motion, where one side of the chest, no, what am I talking? Where they can have decreased chest rise and they can have paradoxical motion. Decreased chest rise on the side that the lungs is collapsing, and they can have paradoxical motion when there is a detached flail segment, which we will talk about later down in the chapter. And paradoxical motion simply means it's moving, one side is moving the opposite of the other side. They can have rapid weak pulse and low blood pressure, definitely shock. Cyanosis around the lips or fingernails, diminished breath sounds on the side that is affected, low oxygen saturation. Chest injury patients often have rapid, shallow respiration because it hurts to take a deep breath. Patient may not be moving air properly if they are breathing shallow. So you know that you need to be worried about the patient losing their ability to ventilate because they're not getting enough air down to the alveoli. It's very important that when you have a trauma patient, especially one that is not communicating, you listen to your lung sounds. Do it in your primary assessment. Listen to the lung sounds. I'm not telling you that you need to listen to every patient lungs. I am telling you that there are some patients it is absolutely necessary for. And if you suspect chest trauma or abdominal injuries, listen to the patient lungs. Very important. All right, now let's look at the patient assessment approach for patients with chest trauma. So starting again with the scene size up, scene safety and standard precautions. Ensure the scene is safe for you, your partner, your patient, and bystanders. If the area is a crime scene, do not disturb evidence if possible. Request law enforcement for scenes involving violence. Call for ALS early. Mechanism of injury. Chest injuries are common in motor vehicle crashes, falls, and industrial accidents and assaults. Determine the number of patients, consider spinal immobilization or spinal motion restriction, whichever guidelines your organization is following. Go with it. And just keep in mind that the new guidelines are spinal motion restriction. After you have completed your scene size up, which is ensure that the scene is safe for you and your partner, bystanders, and the patient. Take the appropriate standard precautions for yourself and your partner. Identify the mechanism of injury or nature of illness, how many patients, whether or not you need additional resources, and consider whether or not you will need spinal motion restriction or spinal immobilization. After you have completed your scene size up, next phase of your assessment is your primary assessment. This is where you will identify immediate and potential life threats and address them. So form a general impression of the patient and the environment. Address life-threatening hemorrhage immediately. Note the patient's level of consciousness. Perform a rapid physical examination as required. So start with your ABCs, LOC, airway, breathing, circulation, airway and breathing. Ensure that the patient has a clear and patent airway. Consider early cervical spine stabilization if appropriate. Are jugular veins distended? Look out for that. Is because if the patient has distended neck veins, it could indicate that there is back pressure being created in the thoracic cavity. So there is something causing back pressure in the vessels. If breathing is present, is it adequate? What is the rate, rhythm, quality, and depth of that breathing? Inspect the chest for decap BTLS IC. Look for equal expansion of the chest wall. So you must observe to see if both sides of the chest is rising at the same time, or one side look low and one side coming up. Not a good sign. Or if you see paradoxical motion, seesaw breathing, one side moving the opposite of normal. Apply occlusive dressings to all penetrating injuries to the chest. Once it's an open chest wound, it's a penetrating chest wound, occlusive dressing 3 sides. Support ventilations as needed. Reassess the effectiveness of ventilatory support. Be alert for decreasing oxygen saturation. Be alert for impending tension, pneumothorax, which is a form of obstructive shock. So if that is present, the patient doesn't have a lot of time. After assessing and managing airway and breathing, next is circulation. Check pulse rate and quality. If the patient can talk to you, radial pulse. Patient not talking to you, carotid or central pulse. Check skin color and temperature. Address life-threatening bleeding immediately. Use direct pressure and bulky dressing. Once you have completed your ABCs, you need to answer some questions. Get in the habit of doing this. 1. What is the patient's GCS? EVM, eye-opening verbal motor, EVM 456. Get the patient's GCS at this point if you haven't done it already. Is this patient a patient that requires a rapid scan or a focus assessment? So do I need to do a rapid scan or do I need to do a focus? Is this a load and go patient or is it a stay and play patient? That comes after your ABCs. So make your transport decision. Priority patients are those with a problem with their X, A, B, C, and X here is for exsanguinating bleeding. That's bleeding that you can't control. Do they have airway issues, breathing, or circulation problems? If it's present and you can't stabilize it in the field, it's a load and go patient. Pay attention to subtle clues. How does the skin appear to you? What is the patient's level of responsiveness? Is there a sense of impending doom in the patient? Does the patient tell you that they don't feel like they're going to make it? Very important. Now, table 30-1 has the deadly dozen chest injuries, and these are the chest injuries that, if present and not corrected, can be life-threatening. And you see which one is number one? Airway obstruction. Airway obstruction. So if the patient don't have an airway, nothing else matters. So these are the deadly dozens. Airway obstruction, bronchial disruption, diaphragmatic tear, esophageal injury, open pneumothorax, tension pneumothorax, massive hemothorax, flail chest, cardiac tamponade, thoracic aortic dissection, leakage from a traumatic aneurysm of portion of the aorta that lies within the chest, myocardial contusion, pulmonary contusion. Now, after we have completed the ABCs, determine the patient's GCS, do a rapid scan or focus, load and go, or stay and play. The next phase is history taking. And if the patient can talk to you, talk to the patient. So it's ABCs. If the patient talk to the patient. Patient not talking, vital signs at that point, and what are your physical findings? So history taking, investigate the chief complaint. Further investigate the MOI, identify signs, symptoms, and pertinent negatives, obtain the sample history. A basic evaluation should be completed. Focus on the MOI. After we have complete history, the next phase is our secondary assessment, physical examinations. For an isolated injury, focus on the isolated injury, the patient's complaint, the body region affected, location and extent of injury, anterior and posterior aspects of the chest wall, very important. So when you're listening to a patient lungs, remember to listen at the posterior end as well. You can hear lung sounds better from the back end or the posterior end. Are there changes in the patient's respirations? For significant trauma, likely affecting multiple systems, start with a rapid physical examination. Use DCAP BTLS to determine the nature and extent of the injury. Obtain your vital signs, and when you obtain your vital signs, your recorded vital signs at this point, compare it to your primary findings. Your primary findings is what your assessment revealed before treatment. Your vital signs at this point will tell you if your treatment is working or not. Is your patient trending up or trending down? So assess pulse, respirations, blood pressure, skin condition, oxygen saturation, and pupils. Reevaluate 5 minutes or less. Pulse and respiratory rates may decrease in later stages of the chest injury. After we have completed the secondary assessment, the next phase is the reassessment. In the reassessment phase, repeat primary assessment, reassess chief complaint, reevaluate airway, breathing, pulse, perfusion, bleeding. Think about your intervention, reassess vital signs, and observe for trends. Provide appropriate spinal stabilization when indicated. Maintain an open airway. Control significant visible bleeding. Place an occlusive dressing over the penetrating trauma to the chest wall, or a sucking chest wound, as it is sometimes referred to. Provide aggressive treatment for shock and rapid transport. Do not delay transport to complete non-life-saving treatments. Communicate all relevant information to staff at the receiving hospital. Now let's look at the injuries. Pneumothorax, commonly called a collapsed lung. This is the accumulation of air in the pleural space. Blood passing through the collapsed portion of the lung is not properly oxygenated. You may hear diminished, absent, or abnormal breath sounds. And here is a diagram showing a pneumothorax. So that white area would be where the air is collecting, and it is compressing the lung tissue. Right? It's compressing the lung tissue. So all of this space is now filled with air. All of that is air. Right? And you can see that there's a significant separation between the lung, the injured side where the lung is. There's a significant separation between the lung tissue and the pleural lining, inner lining. So it's going to affect the process of respiration. Let me remove. Why is this thing freezing up? All right. Now, open chest wound. An open chest wound, often called an open pneumothorax or sucking chest wound. Wounds may be rapidly sealed with an occlusive dressing, which is an airtight dressing. Can be a commercial occlusive dressing, or it can be a plastic improvised occlusive dressing, which can be a piece of plastic, and you can use the bag that the oxygen mask comes in and turn that into an occlusive dressing. If the occlusive dressing is being improvised, then you need to tape 3 sides. You can't tape 4 sides, 3. We need to create a flutter valve so that air can escape, but no air goes in to the area. And you need to monitor the patient so that they don't develop tension, which is a life-threatening issue. With a sucking chest wound, air passes from the outside into the pleural space and back out with each breath, creating a sucking sound. And you're going to see bubbles coming from that wound. Now, with a simple pneumothorax, it does not result in major changes in the patient's cardiac physiology. So a patient can have a collapsed lungs and it does not affect circulation. Commonly due to blunt trauma that results in fractured ribs, can often worsen and deteriorate into a tension pneumothorax or develop complications, so constantly monitor your patient. For the tension pneumothorax now, this results from ongoing air accumulation in the pleural space and increased pressure in the chest. And this is when the air is trapped. So with an open pneumothorax, rarely it will become tension. Tension will develop more from closed rib fractures that cause the rib to puncture the lining. The issue with a tension pneumothorax is the air that is accumulating in the pleural space starts to push on the structures that are in the mediastinum. One of the important structures that are found within the mediastinum is the heart and the great vessels. So it's going to compress the heart and the great vessels, and the heart no longer has room to stretch so that it can fill effectively with blood. So it now leads to obstructive shock. And this creates a back pressure in the veins. This is the patient that will get distended neck veins. It's commonly caused by blunt injury, where a fractured rib lacerates a lung or bronchus. If you suspect that a tension is present, you need to find out where is ALS. This patient needs needle decompression. If you're not in a system where ALS is available, you need to notify the receiving facility. Let them know that the patient is coming in with a possible tension, that they can start preparing to put in a chest tube as soon as the patient arrives. Now, the tension can be so severe that it causes the trachea to shift. So the trachea is actually deviating to the uninjured side. If you see a deviated trachea, that is a late finding. That is a very late finding. Your patient may have less than 10 minutes before they go into cardiac arrest at this point. So a deviated trachea is a late finding. Listen to the patient lungs early. Listen to the lungs early. So a tension pneumothorax can develop if a penetrating chest wound is bandaged tightly and air from a damaged lung cannot escape. The air then accumulates in the pleural space, eventually causing compression of the heart and great vessels. If a dressing sealed on 4 sides with no vent is used, monitor for signs of tension pneumothorax developing and prepare to vent one side of the dressing. Now, the hemothorax. And hemothorax is blood collecting in the pleural space from bleeding around the rib cage or from a lung or great vessel. And a patient can have a combination of blood and air in the pleural space, so they can have a pneumothorax as well. So a hemothorax is a collection of blood in the pleural space produced by bleeding within the chest. When both blood and air are present, the condition is a hemopneumothorax. Now, with the blood, it will not lead to tension. It doesn't lead to tension as the blood tend to pool downwards. Can definitely cause complication because a patient can bleed their entire blood volume into their pleural lining. So they can have a significant deficit in blood volume. And that's what we are concerned about with a hemothorax. Now, regardless of if it is a hemothorax, pneumothorax, or tension pneumothorax, the management will be the same in the hospital setting. The patient requires a chest tube. So chest tube, remove ear and blood. Signs and symptoms. Shock without any obvious external bleeding or apparent reason for shock. Decreased breath sounds on the affected side. Listen to the lungs. Pre-hospital treatment, rapid transport. Rapid transport. If your protocol allows, establish IV access on both sides and run fluid controlled. So the fluid need to be calculated and it need to be controlled. It's not wide open and empty IV bag. You need to calculate how much fluid you're going to give the patient, especially if it is a patient that is bleeding internally. If the fluid is not calculated properly, you can dilute the clotting factors in the patient's blood. So when they go to surgery, they're gonna have serious problems because the clotting factors are not present. So if you're going to be doing IV access or your organization allows that, it need to be titrated based on the patient's presentation. Hemopneumothorax, the presence of ear and blood in the pleural space. Cardiac tamponade. Now, the protective membrane around the heart is the pericardium, and it has an inner lining and an outer lining. So you have the visceral pericardium and the parietal pericardium, and there's another name or other names for it based on the layers, but you don't need to know that at this level. Now, what can happen is the membrane can rupture and bleeding starts to occur in the pericardial sac and compress the heart. When that occurs, that is called a cardiac tamponade. So that is what is referred to as a cardiac tamponade. So think of the heart inside the sac and fluid is around it, preventing it from expanding. Again, this is a patient who will have back pressure in the neck veins. That's going to be common. This is a patient in which if you listen to their heart sound, the heart is going to sound muffled. And of course, their blood pressure is going to drop significantly. A cardiac tamponade is a form of obstructive shock. So cardiac tamponade, also known as a pericardial tamponade, is a potentially fatal condition in which fluid or blood builds up within the pericardial sac, causing compression of the heart's chambers and dramatically impairing its ability to pump blood to the body. It is obstructive shock. Signs include the Beck triad, and Beck triad is distended neck veins, muffled heart sounds, low blood pressure. That's the Beck's triad. So Beck's triad, altered mental status, pre-hospital treatment, support ventilation, rapid transport. And even for me as a paramedic, rapid transport. I was trained how to do a pericardiocentesis, but it's not something I would attempt in the field. Rapid transport. Rib fractures, common particularly in older people or people in contact sports because I have fractured a couple of my ribs in sparring. Fracture one of the upper four ribs, a fracture of one of the upper four ribs is a sign of substantial MOI. So if it's the upper four, because the first 7 ribs are directly attached to the sternum, it takes a significant amount of force to fracture those ribs. So if the upper ribs are fractured, that's a lot of force being applied to the chest. A fractured rib may cause a pneumothorax, hemothorax, or hemopneumothorax. It can also cause a tension gastrothorax. Don't worry about the tension gastro. We're talking about paramedic stuff at that stage. Now, signs and symptoms. Localized tenderness and pain when breathing. Rapid shallow respirations. Patient holding the affected portion of the rib cage. Pre-hospital treatment includes supplemental oxygen. Now, a patient can have a flail segment, and if you look at this diagram right here, let's see if I can put some drawing on it. Put a drawing. So this area right here, if you look at that area, you can see that there is more than one ribs broken in 2 different places, and where the rib fractures are, or the segment that is fractured, is completely detached from the rib cage. Now, because it is completely detached from the rib cage, it will move the opposite of normal. So what does that mean? When we inhale, the rib cage moves out. When we exhale, the rib cage moves in. For the detached segment, when the rib cage moves out, the detached segment will be pulled in. So when the patient breathes in, it pulls in the detached segment. When the patient breathes out, it pushes it out. That's the opposite of normal. And the reason for that is simple. It might seem complex, but it's very, very simple. We breathe in with negative pressure, we breathe out with positive. So the negative pressure is what is pulling the flail segment in, and the positive pressure pushes it out. And that creates an abnormal movement of the chest. We call it paradoxical motion. So that's your flail segment. Now, a patient with a flail segment, the best management for that patient is to take over their ventilations. That's the best treatment. Take over the patient's ventilation and breathe for them. That's it. So pre-hospital treatment for a flail chest: maintain the airway, provide respiratory support if needed, give supplemental oxygen, perform ongoing assessments for complications. Treatment may include positive pressure ventilation with a bag mask device, and that is the ideal management for a flail chest. Positive pressure ventilations. Restricting the chest wall movement is no longer recommended, and that is something we used to do in the past, where we take bulky dressing and secure the flail segment. That's no longer practiced in EMS. The gold standard of care for a flail chest in pre-hospital is to breathe for the patient. Flail chest may indicate serious internal damage or spinal injury. This is a patient that is going to be in terrible shape, terrible shape. Pulmonary contusion should always be suspected in a patient with a flail chest. pulmonary alveoli become filled with blood, leading to hypoxia. Pre-hospital treatment, supplemental oxygen, and positive pressure ventilation as needed. For other fractures, sternal fractures create an increased index of suspicion for organ injury. So if someone has a fracture to their sternum, that's significant force applied to the chest, think about internal injuries. For a clavicle fracture or fractures, possible damage to the neurovascular bundle can occur. Suspect upper rib fractures in medial clavicle fractures. Be alert to pneumothorax development. Now, traumatic asphyxia. The word asphyxia is similar to suffocation, right? Or strangulation, asphyxiation, traumatic asphyxia. So what traumatic asphyxia is, there is something that is crushing the chest. So something fell on the patient's chest and it is crushing it. So the chest cannot rise effectively, and it creates significant back pressure of blood in the vessels to the point that the blood vessels in the eyes can rupture. The patient will have cyanosis of the face and neck. This patient will require aggressive airway management. Need to manage the airway aggressively for these patients. Traumatic asphyxia suggests an underlying injury to the heart and possibly a pulmonary contusion. Pre-hospital treatment, ventilatory support, supplemental oxygen, monitor vital signs during immediate transport. A patient can also have positional asphyxiation. Like for instance, if you restrain a patient that is overweight on the belly surface, their weight can restrict their chest movement and they can get positional asphyxiation. So it's not specific to just traumatic complications. Now, blunt myocardial injury, bruising of the heart muscles. The heart may be unable to maintain adequate blood pressure. Signs and symptoms, irregular pulse rate. An irregular pulse rate is a red flag finding. If a patient has an irregular pulse rate, their heart rate is abnormal. Chest pain or discomfort. Blunt myocardial injury, suspect in all cases of severe blunt injury to the chest, and your pre-hospital treatment, carefully monitor the pulse, note changes in the patient's blood pressure, provide supplemental oxygen, and transport immediately. Now, commotio cordis. Commotio cordis, this is where the legend of the death touch originated from. Anyway, that is my opinion. Right? Commotio cordis is where the legend of the death touch came from, but there's no death touch. But what can happen? So what can happen is a person can be hit in the chest with significant force at a point where the ventricle is about to fill with blood. So the person gets hit very hard in the chest, and that force is transferred to the heart at a point when the ventricle is about to expand and fill with blood. And when that happens, it disrupts the electrical network within the heart, and the patient immediately collapses and goes into cardiac arrest. And usually at that point, they are in ventricular fibrillation, which responds very well to early defibrillation early CPR. So that is what commotio cordis is. It's not that the person have the ability to hit somebody in the chest and kill them. It is that the point of that force, when the force is transferred to the heart, it is at a point when the heart is about to fill, specifically the ventricle. So the impulse doesn't move into the ventricle and it is disrupted, causing cardiopulmonary arrest. It occurs a lot in sports. Again, contact sports. Now, other chest injuries. Laceration of the great vessels may result in rapidly fatal hemorrhage, pre-hospital treatment, cardiopulmonary resuscitation, ventilatory support, and supplemental oxygen if needed, immediate transport, be alert for shock, monitor for changes in baseline vitals. And that would take us to the end of this chapter.